So a 33-year-old man has some rectal bleeding and has a colonoscopy that finds a rectal cancer. This is his rectal MRI performed for local staging, and this is his rectal cancer here. Now, what we say about this rectal MRI is going to help determine this young man's prognosis, and it's going to help determine what happens next. So is this patient going to go directly to surgery with curative intent, or is he going to get neoadjuvant chemoradiation first and then maybe surgery next? And so how do we stage this rectal cancer on MRI? What happens if there's mesorectal nodes or lateral pelvic nodes or inguinal nodes that are abnormal? What if the anal canal is involved? How does that all affect staging, prognosis, and how does it affect management and what happens next? So we're going to look at this case in more detail at the end of this talk, but first I want to cover some basics. This video is part of an interactive course designed to teach you how to read rectal MRI with a focus on staging rectal cancers, taking you from intro to expert level. You'll be able to scroll through MRIs representative of the most important pathologies and stages and learn everything you need to know to become a more effective radiologist. The structure of the course is as follows. So this video will cover introductory material, including the protocol, relevant anatomy, and how to stage rectal cancers with a focus on common pitfalls and common points of confusion. We'll also talk about why staging matters, i.e. how it affects management and prognosis. Then we have a series of carefully selected cases that cover the most important pathologies and stages, how to restage rectal cancers, mucinous cancers, and other rectal neoplasms. It also covers anal cancer staging, perianal fistulous disease, and some other topics. The cases give you a chance to practice while learning the most important concepts. Each case has answers with walkthroughs of imaging findings and teaches you everything you need to know. By the end of the course, you'll have everything you need to interpret rectal MRI more efficiently and more confidently. This course, along with our other MRI and CT courses, can be accessed on our website at navigatingradiology.com. So rectal cancer is common. Colorectal cancer is the third leading cause of cancer deaths in men and women, with rectal cancer making up about a third of those cases. And rectal cancer management is only becoming more complex over time. And before we get into the imaging, I think it's important to briefly discuss the management of rectal cancer in a little more detail. So if the specific details are too much for now, you can rewatch this part after you better understand the anatomy and the staging. But to generalize, surgical treatment is the mainstay. And when we cut it out, we don't want it to come back, i.e. we don't want local recurrence. So to achieve that, the goal is surgical excision with negative margins, which we know leads to a better prognosis and often a cure. And the mainstay of surgery is total mesorectal excision, TME for short, which essentially just means resection of the entire mesorectum along the mesorectal fascia. So there's removal of the rectum and the mesorectum, which includes the mesorectal nodes where the cancer often spreads first. The specific surgical technique will include total mesorectal excision as part of the surgery, along with resection of other structures depending on where the tumor is. So most rectal tumors above the anorectal junction are resected with a low or ultra-low anterior resection, which involves total mesorectal excision and resection of a variable amount of sigmoid colon with anastomosis between the colon and anal canal. In the diagram on the screen, the red lesion is the tumor and the structures removed are outlined in blue. Since the anal canal is preserved, the patients, of course, remain continent. For very low rectal cancers and those that involve the anal canal and sphincter complex, it's a little bit more complex. There's the standard abdominoperineal resection, which has been around for a long time, that involves mesorectal excision and resection of the entire anal sphincter complex. So patients have a permanent colostomy, which is not ideal. Preserving the anal sphincter is preferred when possible. A relatively newer technique that's gaining popularity is the intersphincteric resection. So if the anal canal is involved, but only the internal sphincter with no extension into the intersphincteric space or external sphincter, we'll cover this anatomy later, we can remove part or all of the internal sphincter to get a negative margin while preserving the external sphincter for continence. Again, if that's too much for now, way more importantly at this point, know that we can see this anatomy very well on MRI, so accurate local staging with MRI is key to dictating surgical technique and key to dictating how the patient is initially managed. So how are these patients managed? Well, they start with a rectal MRI for local staging, and then to oversimplify, localized tumors, for example, those confined to the rectum, generally go directly to surgery because they have a high chance of negative margins and a good outcome. Locally advanced tumors that have a higher chance of positive margins at surgery generally have neoadjuvant chemotherapy and radiation first in attempts to downstage before surgery. So first, which tumors specifically receive neoadjuvant therapy first? The answer depends on which guidelines you're looking at and where the tumor is, and there's quite a bit of variability. But for low and mid rectal tumors, it's safe to say that T1 and 2 tumors can go directly to surgery. If it's T3C and above, or it has mesorectal fascia involvement, positive nodes, or is EMVI positive, all things we'll teach you about in this video, patients will get neoadjuvant therapy first. For early T3 disease, so T3A and B, some guidelines stipulate neoadjuvant chemotherapy and radiation first, but most suggest going straight to surgery for low-risk T3A and B tumors. It's also worth mentioning that high rectal tumors benefit less from neoadjuvant therapy, so it's generally not indicated. For those that do receive neoadjuvant chemotherapy and radiation, we use MRI to restage these tumors, and depending on how they respond, they may then go to surgery with curative intent, or if they respond completely, which occurs in up to 1/3 of patients, they can be managed non-operatively with close surveillance that includes endoscopy, CEA levels, and MRIs to look for recurrence. Those unable to go to surgery will continue with chemotherapy and radiation. So why do we give neoadjuvant therapy in these patients in the first place? Well, we know neoadjuvant therapy in these patients decreases the chance of local recurrence after surgery. And for patients with anal canal involvement, for example, it gives us a chance to shrink the tumor and preserve the anal sphincter at surgery so patients don't need a permanent colostomy. This entire management strategy is in contrast to colon cancers that involve the colon from cecum to sigmoid that most commonly go directly to surgery without neoadjuvant therapy and then may receive adjuvant chemo afterwards. If this management overview is too much for now, that's okay. Once we cover the anatomy and staging, you can revisit this section again. The most important thing I want you to take away for now is how important it is to accurately stage and restage rectal cancer with MRI. To accurately stage with MRI, we need the right images and they need to be good quality. So the MRI protocol is key. So for initial staging, our standard MRI protocol includes small field of view T2 weighted images in sagittal, axial, and coronal planes without fat suppression. This is the sagittal T2 weighted image here. Then we use those images to locate the tumor. So for example, you can see the tumor here in this patient and acquire a T2 weighted high resolution oblique axial through the tumor itself without fat suppression. This is the single most important sequence for local staging. Why is that? Well, when staging, we're trying to determine the extent of the primary tumor in relationship to other structures like the rectal wall, i.e., is it confined to the wall? Has it extended beyond the wall? And if so, how far beyond the wall is it? With a tubular structure like the rectum, on standard axials, you're often oblique to the wall of the rectum, so you get volume averaging along with associated blurring, and you will overcall tumor beyond the wall. So notice in this image of an axial through this tumor or through a tumor that it looks like there's tumor beyond the wall along the anterior right margin of the rectum here. With the oblique axial, you're looking down the barrel of the rectum and can better assess whether there is truly tumor beyond the wall. So this is the oblique axial of the same tumor at the same location. Notice that you can clearly see that the tumor is confined to the wall with a well-maintained T2 dark muscularis signal peripherally. So if you remember one thing about the protocol, a T2 weighted high-res oblique axial through the tumor is most important. Of course, done without fat suppression so we can better see the anatomy. Again, do not acquire these with fat suppression. That would make staging more difficult and inaccurate. For low rectal cancers, we also want to know the relationship to the anal canal. So we acquire an oblique coronal T2 weighted image through the anal canal. As part of the protocol, you also want an acquisition with a wider field of view to be able to see lymph nodes up to the aortic bifurcation. At our institution, we obtain T1 in and out of phase images and have the calculated water and fat only images downstream up to that level. We also perform post-gadolinium images, which is optional for initial staging and isn't explicitly required but can be helpful. Post-gad images are definitely helpful in post-treatment restaging though. And we acquire diffusion weighted imaging, which is helpful in initial staging to identify the tumor, but when restaging rectal cancer after treatment, it's one of the most important sequences. It's also worth noting that certain medications can be given to reduce motion artifact from bowel peristalsis and improve image quality, so-called antispasmodic agents. We give buscopan, but glucagon is often also used. Okay, so let's open up this rectal MRI and cover relevant anatomy and the importance of each structure for rectal cancer staging. So first, what defines the rectum on MRI for the purposes of rectal cancer staging? So anatomically, we think of the lower limit of the rectum at the anorectal junction and the upper limit at the level of the sigmoid. But on MRI for rectal cancer staging specifically, the rectum is defined as the distal-most portion of the entire gastrointestinal tract down to the level of the anal verge, which does include the anal canal itself. So for staging on MRI, the most common definition in current guidelines is the distal 15 centimeters from the anal verge. So tumors within 15 centimeters of the anal verge are considered to be involving the rectum. And those tumors are split into low rectal tumors with the inferior margin of the tumor 0 to 5 centimeters from the verge, mid from 5 to 10 centimeters, and then high from 10 to 15 centimeters. Above 15 centimeters would be considered sigmoid, which are managed differently. But the definitions are variable, and there's also obviously variability between patients with respect to the length of their rectum. More recently, there's some good evidence that the sigmoid takeoff is a better marker of the upper boundary of the rectum than a fixed length and can be reliably identified on MRI. So the sigmoid takeoff is the point where the sigmoid takes off horizontally and sweeps away from the sacrum. This is where the mesorectum ends and the sigmoid mesocolon, which contains these tiny spidery vessels, starts at the recto-sigmoid junction, so here. So tumors below this line are considered upper rectal, and those above the line are considered sigmoid. And if the tumor straddles this point, it's considered a rectosigmoid tumor. But remember, different institutions may use different definitions, so it's important that radiologists, surgeons, and oncologists are on the same page. If you remember one thing for now, use within 15 centimeters from the anal verge as rectum. And we say from the anal verge, so what is the anal verge? The anal verge is the anal opening, aka the lower edge of the anal canal. Some people use the bottom of the external sphincter for this, and others use the internal sphincter, which is a little bit higher. Studies show that if you use the external sphincter, your measurement from anal verge to tumor will be longer than on endoscopy. And if you use the internal sphincter, measurements will be shorter than on endoscopy. Either way, it's important to be consistent. The anorectal junction is up here where the internal sphincter ends. For low rectal tumors, the distance from the bottom of the tumor to the anorectal junction is important for surgical planning, but remember, it's the distance from the tumor to the anal verge that defines it. The surgical anal canal is the 3 or 4 centimeters between the anal verge and the anorectal junction. We'll talk a little bit more about the anal canal anatomy when we talk about the sphincter anatomy. Okay, and then above the rectum, we have the sigmoid colon, again, best defined as above the level of the sigmoid takeoff. Okay, so let's look at the rectal wall itself. This is on the axial images here. So on MRI, we can actually see the rectal wall layers pretty well. Most importantly, peripherally, this T2 hypointense layer is the muscularis. And the submucosa and mucosa are more centrally here, the submucosa being more hyperintense. The most important thing to remember, though, is this dark muscularis layer peripherally. Remember, malignancies are often going to be mildly hyperintense to muscle on T2, and the relationship of the tumor to this wall, i.e., is it confined to the wall, beyond the wall, and how far beyond the wall is going to determine the T stage. Next, the mesorectal fascia, or MRF, is this thin T2 hypointense line peripherally here. And this surrounds the mesorectum. So we have rectum here centrally, mesorectal fat surrounding the rectum, and then the MRF, or mesorectal fascia, here peripherally. And that defines the mesorectum. So this is super important in rectal cancer. Remember that total mesorectal excision involves removing the mesorectum along a circumferential resection margin, or CRM, that aims for but is not always exactly along the MRF, or mesorectal fascia. So when we're describing this structure on MRI, we use the term MRF, or mesorectal fascia, rather than CRM. Of course, tumor involving the MRF is bad. There's a higher chance of local recurrence, and it's a negative prognostic indicator. Notice that if I scroll inferiorly, the mesorectum is smaller, so there's less space before the mesorectal fascia is involved by tumor, so it's a little less forgiving in the low rectum. Another very important anatomic landmark is the anterior peritoneal reflection. This is the site where the peritoneum attaches to the anterior wall of the rectum, and we can usually see the anterior peritoneal reflection pretty well on MRI. So in males, like in this case, the location is predictable at the superior margin of the seminal vesicles. So this is the anterior peritoneal reflection here. So you can see this V-shaped structure here that tethers the anterior rectal wall. We can also see it here on the sagittal images. In females, the position is more variable, but visible on sagittal T2 weighted images in the rectouterine space. So why is the anterior peritoneal reflection important? Well, at and above the anterior peritoneal reflection, the peritoneum is closely applied to the anterior wall of the rectum. So we don't consider there to be mesorectal fascia anteriorly here. This here is all peritoneum. And we'll talk about staging later, but if peritoneum is involved, this is a T4A tumor. MRF involvement, like laterally here, for example, would be T3 with MRF involvement. As you go higher from the anterior peritoneal reflection, there is peritoneum both anteriorly and anterior laterally. And then once you reach the sigmoid is completely enveloped circumferentially by visceral peritoneum, of course. Okay, lastly, you need to know the anatomy of the anal sphincter complex. This is super important. When the cancer involves the anal canal, we need to define which parts are involved because it affects stage and surgical approach. The three most important structures are: one, the internal sphincter, which is the continuation of the muscularis of the rectum, composed of smooth muscle here. It's quite T2 hypointense, so here it is on axial images, and here you can see it on coronal images. I'm outlining it with my mouse. Again, a continuation of the muscularis of the rectum. We have the external sphincter here laterally. So this is the continuation of the levator ani musculature. So here's the levator ani, and this is the external sphincter here. This is skeletal muscle, and this is, of course, very hypointense on T2 weighted images. And then you have the intersphincteric plane between the two. So we have the internal sphincter here, and we have the external sphincter here. So the space between is considered to be the intersphincteric space, often composed of fat. Okay, so that's what everyone teaches you. Let's take it a couple steps further. So recall that the surgical anal canal is from the anorectal junction to the anal verge. The anatomic anal canal is below the level of the dentate line, which is about a third of the way down from the anorectal junction. This isn't something that you can see very well per se on MRI, but if you notice that the external sphincter is separated into three bundles, so there's the deep bundle, the superficial bundle, and the subcutaneous bundle. The names are less important than knowing that you can use these as a good landmark for the dentate line between the top two bundles of muscle here in the external sphincter. So you can see between the bundles here where my cursor is, this is a good surrogate marker for where the dentate line is. So why does this matter? Well, remember from medical school that the dentate line is where the epithelial lining transitions from squamous cells in the anal canal below to columnar cells in the rectum above. This is also important because they have different lymphatic spread. So below the dentate line, spreading to the inguinal nodes first. Another point of confusion with the anal canal is the intersphincteric space anatomy. So sometimes the appearance can be confusing. So for instance, here we have the internal sphincter. Here, I'll show it on coronal images. So this is the internal sphincter here. We have the external sphincter laterally here where my cursor is. And then in between where the intersphincteric plane is, we have an additional T2 hypointense linear structure here. So what is that? So this is called the CLM, or conjoined longitudinal muscle, which is a continuation of the outer longitudinal muscle of the rectum. And this lies between the internal sphincter here and the external sphincter here. And the name of this CLM, or the name of this structure, is less important than knowing it exists, so that you don't call involvement of the CLM to be external sphincter involvement. Also note that intersphincteric resection, which is done to preserve continence in patients with cancer involving the internal sphincter, but not the intersphincteric space or external sphincter, includes the CLM as part of the resection. And the intersphincteric space is technically defined as between the CLM and the external sphincter, so this stripe of fat here. This, of course, has surgical implications, and knowing about this structure avoids confusion when looking at these cases. Okay, so now that you know the anatomy and importance in staging rectal cancer, let's go through a step-by-step approach to stage rectal cancer and teach you what you need to know along the way. And we'll use the first case that we presented at the beginning of the talk. When reporting these cases, you should be using a rectal cancer template. The link to the SAR, the Society of Abdominal Radiology template, updated in 2022, is in the description. The template will prompt you for the things that you need to look for. So for now, focus on understanding the concepts rather than memorizing. So step one is to find the tumor. And so to do that, you need to understand the basics of tissue characterization, mainly knowing what tumor signal looks like. So tumor signal is most commonly going to be mildly T2 hyperintense, referred to as evil gray. And it's most often going to restrict diffusion as well. So we pull up the diffusion weighted images here. You'll see that the tumor restricts diffusion. And if we pull up the ADC, you can see that it's dark or hypointense here. Tumors will also often have elevated borders here. So for example, you can see the elevated borders of this tumor here. And there's often accumulation of mucoid material within the lumen outside of the tumor, even in these non-mucinous lesions. So this is a non-mucinous tumor with mucoid material here, demonstrating or around the level of the tumor itself. You can see that here in the lumen, here on the sagittal images as well. Mucinous tumors themselves, which have a worse prognosis, on the other hand, would be more T2 hyperintense within the tumor itself, of course. Ideally, you should be consulting the clinical notes, especially if you're having trouble finding the tumor. Then, if you know the anatomy that we already covered and can identify tumor signal, the rest of staging is just defining its extent, i.e. which structures are involved. When restaging tumors, the principles are similar, but you need to try and differentiate post-treatment change and residual viable tumor. So typically, post-treatment fibrosis is going to be very T2 hypointense and will not restrict diffusion, unlike residual tumor. Also important, after treatment, tumors can undergo a mucinous response. If you see pure mucin pools, which will be T2 hyperintense without internal enhancement, that is a good thing and indicative of response to treatment. We'll cover post-treatment imaging and mucinous response to treatment in more detail in our course. Okay, so once you've found the tumor, the next step is to define the location. So first, we want to define the distance from the anal verge. So as mentioned, this will help us define the tumor as low, mid, or high in the rectum. So this tumor here is about 7.5 centimeters from the anal verge, at least the lower margin is. So this would be a mid-rectal cancer. And the tumor location affects how the tumor is managed and how we stage the tumor. So for low rectal cancers, the mesorectum is smaller, the MRF is circumferential, and the anal canal is close, so we need to look closely for involvement on coronal oblique planes. As you move higher, anteriorly and anterior laterally, the mesorectum is going to be covered by peritoneum, as we mentioned before. So we also want to know the relationship of the tumor to the anterior peritoneal reflection. So here is the anterior peritoneal reflection on the oblique axials, and here it is on the sagittal images. So you'll see that the tumor is below the level of the anterior peritoneal reflection for this particular case. We also want to mention the distance from the tumor to the anorectal junction, which has surgical implications, especially for lower tumors, as well as the height of the tumor. So this one is about 3.8 centimeters in height. As a brief side point, anal cancer, which arises from the anal canal and is squamous cell carcinoma, is staged very differently than rectal cancer. So one, for low tumors that involve the anal canal, make sure that you consult the notes and know if you're dealing with a rectal cancer or an anal cancer. And two, here we are talking about rectal cancer staging. In our online course, we cover how to stage anal cancers as well. In addition to the location, we also want to describe the morphology. So is it polypoid, annular, or semi-annular? And so in this case, it's a semi-annular tumor here. There's also a separate polypoid lesion here more superiorly. This patient was known to have polyposis as well. And we also want to mention if it's a mucinous tumor or not. So again, mucinous tumors would be much higher signal on T2 weighted images and have a worse prognosis. Again, we'll show you examples of that in our course. Okay, and now one of the most important steps is step 3, and that is defining the T stage. So we'll talk through the MRI here, but I've also put a diagram up on the screen as well. So for MRI, you need to know the following. T1 and T2 tumors are confined to the rectal wall. So MRI isn't very good at differentiating between T1 and 2 tumors, so we generally say T1/2. If differentiation is required for management, endoscopic ultrasound is better at differentiating T1 and T2 tumors. T3 tumors extend beyond the rectal wall. So remember that the muscularis layer here peripherally in the rectum is T2 hypointense, and tumor is often mildly T2 hyperintense to this. So if we see nodular tumor signal beyond the wall, that is considered T3 disease. Very importantly, you want to use your oblique axial T2 weighted images for this. Standard axials may overcall tumor beyond the wall, as we mentioned earlier in this talk. Also helpful to know, the most invasive part of the tumor in semi-annular tumors is the midpoint of the C shape, so here. So you want to specifically look here for any extramural extension of tumor. T3 disease, when it's present, is separated into T3A, B, C, and D based on how far outside of the wall it is. T3A is less than 1 millimeter outside the wall, B 1 to 5 millimeters, C 5 to 15 millimeters, and D greater than 15 millimeters. It can be challenging to differentiate T2 tumors from early T3 tumors. So T2 tumors may have a desmoplastic reaction in the mesorectum adjacent that appears as linear, thin T2 hypointense bands like this. So for example, this is a polypoid lesion here that puckers the wall in, and you can see all these very thin T2 hypointense bands here. This is desmoplastic reaction and is not nodular tumor beyond the wall. So this is not T3 disease up here. To call T3 tumor, you want to see nodular or intermediate T2 signal beyond the wall. So for example, here more inferiorly, we do see that there is some nodularity beyond where we would expect the wall to be in the most invasive portion of the tumor. And it's about 3 millimeters beyond the wall. So although differentiating T2 from early T3 disease can be challenging, that being said, depending on where you work, T2 and T3A tumors may be managed similarly and go directly to surgery regardless. T3C tumors with greater than 5 millimeters of extramural extension, on the other hand, is considered locally advanced and will receive neoadjuvant therapy most commonly, but we covered that earlier in the talk as well. T4A disease is reserved for tumors that involve the peritoneum. So this is a common point of confusion, which is why I spent some time on this in the anatomy section. But above the level of the anterior peritoneal reflection here, the anterior mesorectum is bound by peritoneum and not MRF. So involvement of peritoneum here, for example, would be T4A disease and not T3 MRF positive disease. And then T4B disease involves invasion of quote unquote other structures, but the staging system doesn't really clearly define these structures. So this is also a point of confusion. So the current expert consensus is as follows. So any organ or structure outside of the mesorectum, apart from the peritoneum, which would be T4A disease, should be considered T4B because this changes the resection margin at surgery. So T4B disease is best defined as invasion of any pelvic organs like the uterus, vagina, in males the seminal vesicles or prostate or bladder. Also, any skeletal muscle involvement is also considered T4B disease. So for example, the levator ani, if it's involved, would be T4B disease. Also, vessels outside of the mesorectum, so pelvic sidewall vessels, would also be considered T4B disease, and any compartment outside of the mesorectum. So for example, if the tumor were to directly invade the obturator space here, that would also be T4B disease as well. Okay, and then directly related to the T stage are two additional very important things. The first is whether or not the MRF or mesorectal fascia is involved. So for T3 tumors, MRF involvement is defined as tumor within 1 millimeter of the MRF on MRI. So we generally report the T stage, i.e. T3C, and then specifically mention whether the MRF is positive or negative for the primary tumor itself. We also note specifically if a node or deposit is close to or involves the MRF, but this does not have the same prognostic significance as the primary tumor involving the MRF. Okay, and then for low rectal tumors, we also need to describe whether there is anal canal involvement. If there is, we need to describe which structures are involved because it affects surgical management, as we mentioned earlier. Most importantly, the internal sphincter, external sphincter, and intersphincteric space. So this is a different case than we were showing earlier, of course, with tumor signal involving the anal canal clearly here. And so there's clear involvement of the internal sphincter, which is here. So this is all tumor signal involving the internal sphincter. There's also involvement of the intersphincteric plane and that CLM that we described, and the external sphincter is spared. We, of course, want to look at this closely on oblique coronal high-resolution images as well. It's also worth mentioning that one common point of confusion is how anal canal involvement affects the T stage of the tumor. And so the expert consensus is, first, the most important thing is just to describe what parts of the anal canal are involved, as I mentioned already. Second, that internal sphincter and intersphincteric involvement alone does not change the T stage otherwise. And third, if the external sphincter is involved, this should be considered T4B disease. The reason for this is that pathologists consider any skeletal muscle involvement as T4B disease, and the external sphincter is composed of skeletal muscle. Okay, and so then back to our original case. Step 4 is to specifically look for EMVI. So EMVI stands for extramural vascular invasion and refers to tumor extending into the vessels in the mesorectum. So EMVI is a predictor of metastatic disease and is a poor prognostic factor. So on MRI, to call EMVI, you want to see tumor signal that is contiguous with the primary tumor inside the vessels in the mesorectum. So the vessels may be irregular and or expanded as well. So here in our original case, this is the tumor. This is a mesorectal vessel that is not involved, and there's actually no EMVI in this particular case. So we have examples of this in the course, but here's an example on the screen of EMVI. So notice the tumor signal within the vessel itself. Okay, and then step 5 is the end stage. So we're looking along the nodal stations that we already mentioned in the anatomy section and looking for involved nodes. So to determine if they're involved, we look at the size of the node in short axis. So the bigger the node, the more suspicious it is, of course. But size is not all that matters, so smaller nodes can also often be involved. So we also look at the morphology. Specifically, we're looking at the shape. So a round shape is more suspicious. We're looking for heterogeneous signal, which is more suspicious, and irregular borders. So those are the 3 features that make the node more suspicious. So nodes over 9 millimeters in short axis and with no other suspicious features are generally considered to be involved, but even smaller nodes with other suspicious features would be suspicious. We cover this in more detail in our course, but you can use the table on the screen as a guide. In this case, we have a 6 millimeter mesorectal node here on the right that has a rounded morphology, but no other suspicious features. Based on the table on the screen, this should be mentioned in the report as possibly involved, but does not meet criteria to call definitely involved. There are other small mesorectal nodes here as well that do not meet criteria for involvement. So if there was involvement of the nodes, you want to specifically mention which nodal stations are involved, namely of the regional nodes, which includes the mesorectal nodes, superior rectal, and inferior mesenteric nodes as well. You importantly want to mention the highest node involved because they would want to include that in the radiation field at treatment. If there is extra mesorectal nodes, so for example, obturator nodes or internal iliac nodes, you want to also specifically mention those as well. So when you do a total mesorectal excision, they're not routinely cutting out the lateral nodes, so involvement of the lateral nodes may alter or affect the surgical approach. Also, of course, non-regional nodes like inguinal nodes, external iliac nodes, common iliac nodes should also be mentioned. And again, those are considered M1 disease or metastatic. Remember, if tumor involves the anal canal below the level of the dentate line, then inguinal nodes are considered regional and not metastatic or M1 disease. Okay, and so another term that you'll see is tumor deposit. So what are tumor deposits? Tumor deposits are deposits of tumor that are discontiguous from the primary tumor that are not nodes. Based on the best current definition, think of it as discontiguous EMVI. So to clarify, lymph nodes are often seen beside vessels. So for example, in this other case with some lymph nodes here, you can see that this here is a lymph node alongside the mesorectal vessel. And you can see that for all these nodes, they're alongside the vessel. Tumor deposits, on the other hand, tend to interrupt the mesorectal vessels, and we'll show you examples of that in our course. The thought is that these have similar prognostic implications to EMVI, but are still being studied in greater detail. Okay, and then step 6 is to look at the rest of the pelvic MRI like any other pelvic MRI, with special attention to look for peritoneal metastases on the post-contrast images and diffusion-weighted images. Of course, CT will be performed to look for distant metastases as well. So in your summary, you want to mention the following: the tumor location. So for this one, it was a mid-rectal cancer. The T stage and whether the MRF is positive or negative. So here, this was a T3B MRF negative tumor. For low rectal tumors, you want to describe if there's anal canal involvement, and if so, which structures are involved of the sphincter. Here, of course, none. The EMVI status you want to specifically mention. Here, it's EMVI negative. And then the end stage, including whether there are suspicious nodes outside of the mesorectum, and if so, which ones. Here, negative. Okay, so for this T3B MRF negative, EMVI negative, and node negative mid-rectal tumor, at most institutions, this patient would go directly to surgery without neoadjuvant therapy, which is exactly what happened here with a good result. So next, apply what you've learned by working through the rectal MRI cases in our course, which includes examples of all of the important stages and what they look like, examples of other rectal neoplasms, anal cancer, perianal disease, and other topics. Each case comes with answers, walkthroughs of imaging findings, and teaches you everything you need to know. So to access the rest of the course, go to navigatingradiology.com. Thanks.